Rusty.
Hi.
How do I treat my thin endometrium?
So really, first of all, we need to establish cause for the thin endometrium. There are three main causes for thin endometrium. Anatomical, due to trauma, and due to inflammation. So anatomical means the patient has anatomical variation in the uterus. We call it Mullerian abnormality. So it can be due to arcuate uterus, bicornuate uterus, or uterine septum. If it's uterine septum, that needs to be removed. So that overall improves uterine thickness, endometrial thickness, and improves a chance of implantation. So arcuate and bicornuate uterus, you don't need to treat, and that thinner endometrium, let us say 6 millimeter endometrium, is normal for that patient. You cannot treat and you shouldn't treat. The second is due to trauma. So there are two main causes for traumatic thin endometrium due to a condition called Asherman syndrome. So in Asherman syndrome, the uterine cavity has a scar tissue. So that could be due to uterine surgeries, let us say myomectomy. If you had a myomectomy with a laparoscopic and open myomectomy, if there was a breach into the uterine cavity, so if it wasn't treated immediately, then you may have scar tissue inside the uterine cavity. Because basal stem cell layer, which is demarcation line between muscle and endometrium, has been breached, and then there's a defect, and the defect is closed by secondary scar tissue formation, adhesion formation. So, and also another very common cause for thin endometrium is untreated retained products of conception after miscarriage. Let us say if patient had a miscarriage, there was some placental tissue was left, it wasn't detected, and because of defect on the basal endometrium, they have adhesion formation. So stromal cells grew over endometrial plate, and patient has Asherman syndrome. So in Asherman syndrome needs to be treated hysteroscopically. So we call it hysteroscopic adhesiolysis. So in hysteroscopy, you establish the contours of uterine cavity and remove the adhesions. And normally you do follow-up hysteroscopy after months or 2 months to ensure that adhesion has not reformed. So the third type of thin endometrium is due to inflammation. That's due to adenomyosis. In adenomyosis, what happens is the endometrial lining starts growing into myometrial lining. Normally, you have a very clear demarcation line between muscle and endometrium, which is defined by stem cell endometrial lining called basal endometrium. So you should not, this basal endometrium should not invade into the myometrium. So what happens in adenomyosis is every month when patient has menstrual bleeding, they keep eroding the basal endometrium. So you have a thinning of the plate of the basal endometrium. When you do ultrasound scan, you cannot tell where the myometrium ends, where endometrium starts. And this demarcation line becomes very hazy, and they have a thin endometrium. This needs to be treated by giving a break to the uterus from monthly estradiol production and the monthly period, which means you need to stop the menstrual period for at least like 4 months, 6 months, to give long enough time for the basal endometrium to restore itself. So stop the erosion of basal endometrium. For that, you use something called generate agonist drugs like Zoladex, Prostab, decapeptide drugs to stop menstrual period, so that uterine lining will restore itself. So really, treatment of thin endometrium starts from understanding and establishing the cause of thin endometrium, then addressing the cause directly.